Salutations to the Almighty, my loving Master, loving greetings to all the assembled doctors here. Dear doctors, I'll be making my presentation today under three distinct and specific headings. Firstly, defining and outlining the difficult and perhaps dangerous situation which is confronting the human race today in the form of what we call the NCDs or the non-communicable diseases, especially cardiac diseases. Secondly, an analysis of the reasons for this grave situation. And finally, providing a practical, workable, time-tested solution which has been innovated by our Bhagwan Sri Sathya Sai Baba, our Divine Master. Dear doctors, you will all agree that there has been a tremendous and spectacular advances and improvements made in the field of cardiology and cardiothoracic surgery. I have listed a few, but I am sure you will agree that there are many more, to the extent that I would say sky is not the limit for such improvements and advancements. But paradoxically, this is a very big but. Paradoxically and unfortunately, if you see, the cardiac community disease load, a very important term used in public health parlance, which tells us the utility value of all the interventions that are made in the specialty. Unfortunately, that disease load has been increasing by leaps and bounds, and it is so distressing to see that it accounts for 32% of all deaths the world over. But the most worrying factor is that in a country like India, 50% of all these acute events, especially acute myocardial infarction or heart attack, occurs in individuals below 40 years. This is a very sad state of affairs. If we analyze the reasons for this upsurge, this sort of a dangerous situation which we are faced with, I have listed 5 reasons. The first is socioeconomic poverty, unaffordability. This is the domain of politicians, bureaucrats, economists, so I'll not dilate much on that. The second is the dramatic increase in the incidence of diabetes and hypertension. Other speakers are addressing that issue. I will confine myself mainly to these 3 important reasons. Even in this, the first, defective healthcare system, and secondly, the near total absence of focus on prevention. These are important. The second one is an offshoot of the first problem which we have. Dear friends, we all know that with the advent of industrialization, in every country, there happened what is called a phenomenon called rural-urban divide. That is, people who are working in factories and industries, they settle down in communities which we call as cities and towns, and these cities and towns became the epicenter of all progress, of all development. Whereas people who stuck to agriculture as their occupation remained in communities which we call villages, but they remained totally cut off from the mainstream. This aspect has not been taken into consideration when the healthcare planners devised the healthcare services for many countries. And in a country like India, especially, as you can see, it is so defective. The 3-tier pattern of healthcare services, which was devised by a committee called the Bore Committee, did not at all take into account the fact that 70% of our population still is in villages. So 70% of the population is serviced only by primary healthcare centers, and you know how primary, how rudimentary, I should not, maybe if I'm using a stronger word, they are. Whereas 30% of the population, the urban population living in towns and cities, are provided with all the 3 levels of care. This is not just a gross inequity, but I'm emboldened to say this is a gross injustice which has been perpetrated and perpetuated by successive governments on the poor Indian villages who constitute 70% of the population. And not only that, rural healthcare delivery is caught by field experience of 25 years on the field. I can tell you, it is caught in what I would call a tricky triangle. The 3 limbs of the triangle are, on the one hand, government's challenges, on the other hand, doctors' reluctance to go to serve in rural areas, the base being constituted by the constraints which the villagers have. If you take the government's challenges, we have poor budgetary allocation. Very importantly, government always says it pleads its inability to transfer technology, especially in the form of diagnostic equipments. As you know, modern medicine is all about diagnostics. The government feels that there is no mechanism to install it, service it, or to attend to it if it becomes faulty. And as you know, the inputs from on-site, on-the-field experts is never really taken into consideration, and the health department in our country is manned by bureaucrats. And not only that, this obviously leads to improper planning. The second limb of the triangle is, as I said, doctors are not willing to serve in rural areas, and they cite both professional and personal reasons. Professionally, you can understand an MD passed a doctor goes to a government primary health center, there is not even a glucometer. There's no diagnostic worth its name. So he becomes totally dissatisfied. And personal reasons like absence of schools for his children, after all, they are young doctors. So rural service is totally unattractive, and there are no takers for this. The third limb of the triangle is constituted by, as I said, the constraints which the villagers have to access the facilities which are available in towns and cities. And this Bhagwan mentioned to me personally when he started his beautiful marvel, which we shall see in the next few slides. Villagers being engaged in daily wages, senior citizens, nobody to take them to the hospitals, they don't have enough money for transportation charges, and women in villages don a dual role. They have to work both at home and in the fields. So it's a very difficult situation. It looks an unsolvable problem. We are literally driven to the wall. The second, as you can see, the consequences of this are, as I said, 70% being in villages, 80% facilities being in towns and cities. Public health parameters like infant mortality rate, life expectancy, obviously, the figures of rural areas compare unfavorably with that of urban areas. But dear doctors, an important point which I want to make at this juncture, which I did not mention in that slide, is that there is no integration of primary, secondary, and tertiary care. They function in tubular compartments. I'll give you a simple example. A villager with a chest pain and a foot angina goes to a primary healthcare center. There is no diagnostic there. Maybe even if there is an ECG, he would say, go to a higher center, a city in town. But there is no mechanism, there is no way to escort, to guide. This is not a guided journey for the villager, and he doesn't know where to go far off towns and cities. He gets lost in the way, or he may not go at all. So there is total lack of integration. We have coined it as primary, secondary, and tertiary, but for the poor villager, it means a great loss and suffering. And the second major reason in my prefatory note, which I cited, on the one hand, the defective delivery system. The second is total absence, I can say, of focus on preventive services. Let us be frank enough. And we have this slide of our fatherly and legendary figure, Dr. Christian Barnard, who at the end of his career lamented, felt so bad, miserable, that he had spent his lifetime doing 150 heart transplants and saving the lives of 150 people. And he considered that if I had spent my time in educating people on cardiac health, maybe I would have saved 150,000 lives. And we have the World Health Organization reports, which says most, if not all countries, even the developed countries, spend only 3 to 5% of their medical budget on prevention, though they are acutely aware of the fact that if they spend $1 on preventive education or preventive services in a very programmed way, not in a haphazard way, the way I'll show you how our Bhagwan taught us, then we can save $10, or that is equal to $10 spent in curative services. These facts are very well known, but for inexplicable reasons. It is a big maya, if I can use a philosophical word. And not only that, there is an unexplained lack of interest, we should all concede, among doctors for the important need of prevention or to spend their time on prevention. And this fact also is very important, that modern discoveries, which have really radically transformed our concepts about nutrition, especially directly connected with the NCDs. These topics, I'm so sorry to say, most of our doctors are not aware of it, like circadian rhythm, nutrition. Nutrition just doesn't mean some healthy food. Radically, as Dr. Mohan was describing in the morning, how carbohydrate is not the culprit. It is inappropriate carbohydrate. That is, it doesn't match with our occupation. It is a ready fuel which has to be burnt. But if you don't burn it, you take a laddu of 30 grams of carbohydrate and sit on the table and do your computer work, then what happens? The cells say we are enough. We don't want the carbohydrate. So obviously it gets transformed into fat and goes into around the organs as visceral fat or as subcutaneous fat. So all the modern discoveries which have been really highlighted by one Dr. Sachin Panda of the US, San Diego, he's based, especially autophagy. For autophagy in 2017, the Japanese scientist who really uncovered it was given a Nobel Prize. But we don't know anything about autophagy. Again, gut microbiome and leaky gut, we all know, is the talk of the day. Sleep, relaxation, exercise, all these things, the modern concepts. In fact, the best time to do exercise, my dear doctors, you'll be surprised to know, is between 4 p.m. to 5 p.m. And there are enough reasons for it, how it is based on the circadian rhythm. But I don't have time to dilate on all these things. But believe me, our Bhagavan always says, chase in the cheppu, chip in the chai. You practice what you're talking about, and you talk what you're doing about. So I had experimented on all these aspects, and I'm so glad to tell you that in a period of 1 year, I lost 18 kgs, and all my metabolic parameters came back to normal, including HSCRP, including serum homocysteine levels, all these reversed to normal. So anyway, there's an urgent need to update doctors on these 5 important topics. And as I said, when the healthcare service itself is defective, there is no portal to transmit preventive education. There is no portal either for curative services or for preventive services. And again, preventive services cannot be a sporadic, once-a-while window dressing exercise. It has to be a serious, regular, and sustained service, and it has to be done primarily by doctors. Please remember that if done by doctors only, there will be credibility and receptivity. Please do not leave it to counselors to do it. You have to do it, but it can be reinforced by counselors and by paramedics. Anyway, the solution for this twin problem of defective health service on the one hand, lack of focus on prevention on the other hand, was left ultimately to our Bhagwan to deliver what I would say the master's masterstroke. Having provided primary healthcare services in the form of the general hospital, tertiary healthcare services in the form of the super specialty hospital, in the third phase of evolution of the medical services of Bhagwan, Swami made a 3-pronged approach. The first, he declared that for medical service, we all know the 3 Ds, doctors, diagnostic, drugs, that is not enough. He said the 4th dimension, the 4th requirement is delivery, especially in a country like India where people are cut off from the mainstream. You have to reach out to these people. And secondly, Swami said, once it is an outreach process, you're going into the community, you're doing a curative service, there will be a huge level of goodwill and respect which is generated by this service. You are the best to do the preventive service, and hence he gave us that beautiful triangle, a fine combination of curative preventive services with base as spirituality. And in this way, as I pointed out, the defect of non-integration of primary, this got solved because the mobile hospital, as you will see, on the field we deliver primary and to some extent secondary care, but tertiary care, we ensure that the journey of the patient is guided. We ensure that the end-to-end solution is generated. And recently also, you will all be aware that we had done 3 major surgeries, gastro surgeries in the department of super specialty hospital. It was undertaken by the mobile hospital. So all the 3 are enclosed in a common capsule. So this becomes the 4th dimension, as they say of reality, the 4th dimension of true medical care. And this is the beautiful marvel, the model which Bhagavan innovated as Sri Sathya Sai Mobile Hospital. Can you believe that it is now 20 years old or 20 years young? A sustained outreach, high-quality, multi-specialty service. Very quickly, I'll run through through the slides because of constraint of time. Such a service, manned purely by voluntary doctors. Can you imagine it has been going on for 20 long years with the same strength as it has been right from the day of inception? Anyway, the nature of this service is that it is a free rural outreach, comprehensive, high-quality service benefiting very modestly 300, but actually about 400 to 450 villages because the whole data is computerized. Can you believe on the field computerization is done everywhere, even though the nodal villages change every day? And it benefits a population of about 5 to 6 lakhs of 12 mandals. It started in March 2006, as I said. It operates from the 1st to 12th of every month at fixed what we call nodal villages. Whether it is going to be Dasara on 2nd or Deepavali or Christmas, the doctors are invariably there. This generates faith in the minds and hearts of the poor villagers and gives credibility to your program. As you know, every service, when we start it, we need to have an ideology. That becomes the guiding theme. That ideology has to be translated into a workable methodology. So we have a beautiful operative theme about which you have already seen. A fine combination of curative and preventive services with spirituality as the base of it. Excellent operative strategy, which consists of, first, classification of community ailments. This is a very important secret which I learned on the field by virtue of my 25 years of rural service, having traveled about 12 to 13 lakhs of kilometers on the field. And ailments of any specialty you have to classify as common, chronic, intricate, asymptomatic, preventive, and medical emergencies. So when you have this fine classification of each of the systems, ENT, cardiology, or anything, you will automatically develop an operative strategy. And you know what is the community disease load of that particular disease, the community disease spectrum, as we call. Once you have an idea by classifying this, your operative strategy will be excellent. The next operative strategy is, as I said, it is a very regular and a fixed service operating in 12 nodal villages. You should ask me why it is not beyond 12. I'll tell you when I meet you individually. The next highlighting feature is Bhagavan was very particular that the service should be of a, Yes. He was very particular that it should be of a high standard. Vaidya nipudulu undali. This is what Swami exactly used the word. So on any particular day, believe me, in a rural outreach setup, there are doctors belonging to 12 specialties, and they all work in close coordination. They don't work in watertight compartments. Even in a city, in a corporate hospital, it is impossible to meet 2 doctors, I'm telling you today. But in this setup, so many doctors, like there is a patient with uncontrolled diabetes. He or she is immediately sent to a dental surgeon to see. We all know periodontal disease is a common cause of lack of control of hyperglycemia. They immediately do a scaling and send back. So there's a fine coordination and cooperation among the doctors. The ultimate beneficiary is the poor villager. The next requirement which Bhagavan had highlighted, and he gave us that beautiful bus, he said, having gone all the way there, you should not say, write a slip and tell the patient for an X-ray to go to a town like Anantapur. You have gone in. Meer lopala vellaru, vallan bayta tarmistunaru, em lavam, he said. And he said, that is why I'm giving you that beautiful diagnostic bus, which has got digitized X-ray, a lab, an ultrasound with a color Doppler, ECG, EEG, and we also do fine needle aspiration cytology, and that is called on-site diagnostics. But again, as I said, we should be able to escort the patient totally in his journey. There is a mechanism for achieving off-site diagnostics. It is IT-enabled. Like, for example, CT scan and MRI scan, you can't have portable variants. The whole journey, the patient is guided by the system. And the next requirement Bhagwan had highlighted was, you may be the best doctor, you might have done the best of diagnostics, but ultimately if you give only a prescription, it's a waste because they can't afford to buy it. And that is why we have a very rich pharmacy. And in this context, when we are talking of NCDs and cardiac diseases, I'm so glad to tell you that our master has devised a system where we give the patients 1 month medicine to ensure uninterrupted use of medicine. The compliance level thereby is very high. These are diseases which require, as you know, every month examination, monitoring, counseling, but most importantly, uninterrupted supply of medicines. And also, we need a viable backup support. 10% of ailments on the field, we find they require higher level of treatment or higher level of diagnostics, especially surgeries, as you know. But the process of case identification, diagnosis, even surgical profile to the extent of determining LV function is done on the field. And in the general hospital and in the super specialty hospital, we are given 1 week to take up our cases. And we have Dr. Rajan Anand, our head of anesthesia, who has been kind enough to accept any case which we post. And the team, there are 350 doctors belonging to 15 specialties. Mr. Ratnakar was mentioning in the morning, all voluntary. Oncosurgeons, we have got 6 oncosurgeons. We have all varieties of doctors. So not only that, after my taking over as the head of the general hospital, I have ensured that there is a fine integration of the human resources of these 3 hospitals. Like I said, 3 surgeries which we did. The patient, 1 patient was from the super specialty hospital, the head of the HR department, 1 patient was from a village, 1 patient from the general hospital. The surgeon was from the mobile hospital, the anesthetist from the super specialty hospital. After a few days of immediate post-operative care, patient is brought back to general hospital. So Swami always liked unification of efforts in any good work, and we all know he said that it is unity which leads to purity and divinity. And finally, most important slide, as I said, Mr. Ratnakar was also mentioning, the focus on prevention is huge. Preventive education is both done intensively and extensively. And on the field, I have learned these techniques. It should be done firstly at the individual level during the course of doctor-patient interaction. Every doctor's table should have flip charts, should have demonstrative material, and he is the right person to really educate the villagers. Of course, in the midst of so much of rush which we have in the hospitals, it may not be possible, but there is definitely what we call prioritizing. You prioritize some patients, or you decide on a particular day. But at the individual level, also health education is important. It can be done at the family level. And this we might have done umpteen number of times in the village. We divide ourselves into 2 teams. We make a group of villagers, adjacent houses to sit, and we very informally interact with them. And as I told you, there's a huge goodwill generated by the curative service. So if your curative service is strong, then people are prepared to listen to you on aspects of prevention. Then this can be done at the group level also. In every hospital, there are about 100 patients in waiting. One doctor can go up with a stethoscope and then talk to the villagers on these aspects of prevention. Or what I do, a child with malnutrition, I pick up the child. Villagers are very rustic. They don't mind. And I tell the whole lot, this child is so malnourished, so thin. See his hands. I even say, if I say who, he'll fall down. So I then enumerate the causes for malnutrition and then advise them that they should see that their children don't fall into these situations. So health education can be done at the group level also. And finally, in the end, in the evenings, after 7 p.m., we reach out to the villagers and do health education at the community level. The whole village is taken into confidence. And this is done in a very innovative way. And this is combined with also practical demonstrations. It generates a huge goodwill. And I'm telling you, my dear doctors, olden days when we had cholera, smallpox, chickenpox, scabies, measles, mumps and all, the solution was first a germ theory came, then an immunity theory came, thereby antibiotics, sanitation, antiseptics, immunization all came. But for the current problem which is facing the human society, Dr. Mohan was mentioning, half of individuals above 50 are diabetic. There are no external agents. Maximum, they may reduce the blood sugar. The onus is on the individual to change his habits. I don't like using the word lifestyle habits because these are life killers. Life-transforming habits is the word that has to be used. Anyway, health education has to be done at these 4 levels. So I have outlined the problem that cardiac diseases are on the rise. because of increase in incidence of diabetes and hypertension on one side, but more importantly, there is no effective healthcare delivery system, especially in a country like India. And secondly, the total lack and absence of focus on prevention. And really, doctors have to rise up. And unless they do health education, I am telling you, we are the community who have been given the mandate by the Lord himself as doctors, Vaidya Narayana Hari. We have to play our due roles. Otherwise, it is going to be a very difficult situation. Final slide, I would conclude. I had mentioned the triangle of holistic healthcare in which the base was spirituality. Spirituality, Swami clarified, does not pertain to any religion or race or any leader or cult. No, it refers to the broad ideals which Swami had enumerated, and also to practices which are common to any and every religion, like prayer and meditation. And thereby only you can ensure holistic health, because modern medical experts have clearly shown us, have clearly realized that holistic health means a fine combination of what we call metabolic health and mental health. And this mental health, we clarify to the villagers, does not depend on doctors, drugs, tonics. No, it is left to you only. So this is a beautiful model innovated by our Bhagwan, which provides effective solution to the COVID-like situation. I'm telling you, right now when I go to the periphery, the villages, my heart bleeds, my heart aches. Because to see the volume, the number, India is a populous country, to see the number of patients with these diseases, and the only solution is this sort of an outreach care, which not only enters the community, but penetrates into the community. Swami told us, "Meer enter kaadu, penetrate avali." ఎక్కడ పెనట్రేట్ అవ్వాలి? వాళ్ళ లైఫ్ స్టైల్ హ్యాబిట్స్, దాని తర్వాత వాళ్ళ హృదయంలో మీ ప్రేమతో నిండిన సేవతో వాళ్ళ హృదయంలో మీరు పెనట్రేట్ అవ్వాలి. అండ్ ద లైట్ ద ల్యాంప్ ఆఫ్ స్పిరిచువాలిటీ, that is the larger purpose of medical service. This was what Bhagavan had told us. And the finally, take-home message we need to have, there's an urgent need to have ideal healthcare delivery systems. And I'm so glad to tell you that the mobile hospital model has at last attracted the attention of governmental agencies, healthcare planners, and they are in touch with me. 2 governments are in touch, and they want to replicate it. But we have shown it to them that from the governmental angle, how do you handle, especially as we know, 3 M's, manpower, material, and money, the manpower part, how do you handle it? The suggestion which we have given is postgraduate doctors in 2nd and 3rd year, instead of asking them to do rural medical service after they finish their course, when they want to embark on a higher journey or when they want to set up their own practice, not that time. During their course itself, 2nd and 3rd year, they're qualified doctors, they're registered doctors, and they're quite good in the subject. And as you know, government hospitals are all managed by PGs only. They should be drafted into the service. We have shown by figures how many mobile hospitals are required for a state like Andhra Pradesh, how many PGs are available. We have found that by Swami's grace, the equation matches very well. So anyway, there's an urgent need to have such outreach service system, urgent need for doctors. Please excuse me if I'm reiterating it, that we need to really update our knowledge on those 5 topics which I had mentioned. And there's an urgent need for governments to step up, to scale up their budgetary provision, especially for preventive services. I think with this strong take-home message, we would have achieved the purpose of emphasizing on the role of prevention, because after all, the theme for this conference itself has been on preventive service. I thank you all for your patient hearing and thank Bhagavan for giving me this opportunity. Jai Sai Ram.